Barker.
Good morning.
Good morning.
Great. My name is Bret Barker. I've seen so many familiar faces here over the past 2.5 years. Again, I'm an FNP-DNP student. My presentation is on the program evaluation of cognitive behavioral therapy in veterans with insomnia at the Oakland Behavioral Health Clinic down the street on 21st. Dr. Kate Shade is my practice chair, and my practice mentor is psychiatric nurse practitioner Greg Roussett at the clinic. So insomnia is a big problem, especially when it comes to veterans. Over 21.8 million veterans are alive in the United States as of 2010, and of those, over 270,000, about 70% of them have some type of sleep disturbance, such as insomnia. Insomnia aggravates a lot of underlying condition. It increases depression, and it can aggravate PTSD, whether it's been treated or not. There still may be some residual symptoms with insomnia that can affect quality of life. It is a predictor of the degree of depression that veterans may have, and also a predictor of the severity of PTSD symptoms, such as recurring nightmares, which will further aggravate the insomnia. So a clinic visit for insomnia was associated with an increased risk of suicide. A clinic visit for insomnia 12 months post-deployment actually increased the risk of suicide even greater. And treatment of insomnia does reduce acute stress, especially with PTSD. Some of the treatment options available through the Department of Veterans Affairs include pharmacology such as Prozocin, of course SSRIs, NRIs. About 50% of veterans that are being treated with insomnia are getting pharmacological measures. Currently, the Veterans Affairs nationwide is promoting the use of CBT-I for first-line treatment for insomnia. Our CBTI program at the Behavioral Health Clinic is a 6-week group intervention. If a person misses, they can do a follow-up with an individual session, but it contains 4 components. So we do stimulus control therapy. So what we do with that is we prescribe the bed for use for sleep and sex only, so they don't associate the bed with insomnia. So if they're ruminating in their head, they're specifically told to get out of bed, read a magazine, work on a hobby until they're tired, and then go back to sleep. We also prescribe sleep restriction therapy. So we prescribe the time for them to go to sleep and what time they should awaken. So if they want to get up at 6 o'clock in the morning, we set their bedtime for 10 p.m. They don't go to bed longer than that. From there, we can calculate a sleep efficiency score, which I'll get into a little bit more. We also teach them cognitive restructuring, which they use tools that we hand out to them, as well as a sleep diary that we review weekly to gather data. And we teach them some sleep hygiene practices that I think we can all use at times. Mm-hmm. So cognitive restructuring is the basic thought leads to feeling, leads to urge, leads to a behavior, and it's a vicious cycle, the T for principle. So negative thoughts lead to negative emotions and negative behaviors. So with cognitive restructuring and not associating the bed with insomnia, persons may get better sleep. This is one example. So we're going to evaluate the effectiveness of the CBTI program delivery at the VA Oakland Behavioral Health Clinic. They've been running this program since 2014. They run, 2014, they've done 6-week sessions ever since. They probably have 45 or 50 persons that completed the full 6-week session. They have a full range of treatment, including that for drug and alcohol, polysubstance abuse disorders, medication management for chronic conditions such as hypertension, diabetes, etc., methadone maintenance for those coming off of opiates, and as well as individual and group therapy. And they have some services for homeless, and you can go take a shower and wash your clothes if you're living under the bridge on Grand Avenue. They have a psychiatrist and a psychiatric nurse practitioner on staff, as well as about 20 different support staff personnel to help with that clinic. So inclusion criteria for those who participated.
You missed a slide.
Did I skip one?
Yeah.
Oh, design. I'm clicking away here, and my mouth is going faster. So this is a quasi-experimental design using repeat measures of sleep efficiency to determine the relationship between the CBTI dose and the self-reported improvements in sleep. And so by dose we mean a full 6 week of therapy, or we're going to measure if they got 3 or less weeks of therapy and was there an improvement in sleep. We do have some attrition where people receive the training, they get their sleep diaries, they understand in a couple weeks out they're doing better, so we want to see what that dose reveals. There was a study at the VA in San Francisco. They did an 8-week controlled study, and they found some of the same situations with about 45 participants. Some left the study early because they got benefit. They didn't feel they needed to come back. So we want to see what that dose is, especially with veterans that may be on the move, they may be local, they may be going from town to town, or they may not be able to get to the clinic. We want to give as much intervention as we can, because 6 weeks can be quite a long time for people if they don't have transportation, and even if they do. So sleep efficiency, again, that's it's a pretty basic calculation that we use. We measure each week according to the self-reported sleep diary, and that is total sleep time divided by the time in bed, and it gives us a ratio multiplied by 100. So if you spent 8 hours in bed and you got 6 hours total sleep, your sleep efficiency is 75%, which is pretty good, versus you spent 8 hours in bed and only slept for 4 hours. That would be a ratio of 50%. So our participants, it's a self-sign-up program. So they come into the clinic, they have signs on the wall, they can request to sign up for CBTI therapy, or they can be recommended by the psychiatrist or the psychiatric nurse practitioner. So all participants were vets that participated in any healthcare at the Oakland VA Behavioral Health Clinic are included. We have variable risk categories, including gender, other demographics, age, number of deployments, time that they're in deployment, other measures that we can look at. Our independent variable is, of course, the CBTI number of sessions or the dose, and we're looking at who completed all 6 sessions versus those who completed less than that, typically 3 or less, or about 50% of it, to see if that was still an effective dose. Our dependent variable is that calculated sleep efficiency as described. So the procedures for the delivery of the program, I did a 2-day course on CBTI therapy with the Uniformed Services University on a webinar. We deliver it to about 6 to 8 participants at a time that sign up. If we don't get enough sign-ups, sometimes they won't do the treatment plan, but it's slated and scheduled for starting every 6 weeks. We get a consent for data to be collected. The data has been collected by the practice mentor. At this time, I've not seen any of it. The data will be de-identified. We're hoping to get a postdoc student in there to help with that, so that we can seek IRB approval. Our analysis will be using repeated measures analysis of the variance or ANOVA for our baseline, mid-treatment at that 3-week point, and post-treatment sleep efficiency scores at 6 weeks out. Comparisons of 6 sessions to that 3 sessions or less is the numbers that we're looking for to see if there's a dose relation to whether they got 1 session, 2 sessions, 6 sessions. Hopefully further studies down the road can look at follow-up data to see if there's any residual insomnia or if they need any type of retraining, if there could be some reinforcement that can be done at the end, but work on that. Today's a good one. All right, so project cost and financing. Truly, it's just travel costs for me to come up here from the Monterey Bay and my time, as well as the staff at the VA facility. So I'll be coming up on Mondays. They do the group therapy sessions Mondays from 10:30 until noon. So I'll be up here weekly on Mondays to help with that. If we do not get IRB approval, if we do, then I'll be looking at de-identified data. I've got my badge and got clearance to the VA and all that, so I can get into the system and look at stuff. So our timeline, I got my CBTI education as I've been doing this research as well as the USU course I took a couple weeks ago. We are seeking for IRB approval. We made some contacts, and thank you, Pamela, for helping with that. So we can seek what that process entails, because it is government, it is the Department of Veteran Affairs, so we're going to have to go through procedures to get that done. We plan our evaluation, review some sample data with the practice mentor to see the tools and measures that we have to work with. If we don't get the IRB approval, we'll co-lead CBTI groups on those Mondays I mentioned. But if we do get that, I'll get a draft and present a proposal to the Oakland Behavioral Health Clinic, Northern California, and as well as San Merit IRB. We're going to collect the retrospective data then on the participants that completed their CBTI through their EHR. So if I'm doing that data myself without IRB approval, that'll be pretty quick. We'll just have to see what we're doing with the identified data. So we're going with that. I'm not looking at anything specifically, that way I don't dirty the study, as it were. So we'll also plan to do a prospective data collection for participants who are getting their CBTI between last month, a new course started, through the end of probably June or July of next year, where I'm going to implement a couple different measures that you have a baseline insomnia severity index, or ISI, which is scored from 0 to 17, and typically with CBTI in studies they found a drop in about 7 points on that, which is a great predictor of a decrease in insomnia overall, and then the way it affects depression, PTSD, anxiety, and such. So I want to do that measure at least weekly instead of just a baseline. And then there's some other calculations that I want to do in my variable table. That's all listed out in my wonderful paper I'm writing. So next summer, hoping to have that data set in Excel, have all the data collected, put in. We're going to use IBM SPSS 24, this is the system I currently have, analyze the descriptive statistics about the sample, working with Demir, looking at our sleep efficiency improvement so we can see at what dose we start to see improvement, if it continues or decreases, or if it flatlines, or if they get continued improvement. We truly can't get to 100% sleep efficiency. That would be great if we just turn off like a light switch and turn back on. But I think 75, 80% is a pretty good target. That's what's been seen versus the 40 to 50%, which is quite harmful. So we'll report our findings and program evaluation next December and publish it if we have IRB approval. It'll be an internal report otherwise, and then that can go on to further study after that. So, any questions?
Dr. Ramirez.
Thank you, Bret. I personally find this an interesting study. I have a couple of questions, very quick. Do you expect most of your participants to have PTSD?
Most of the participants would probably have PTSD, but they would have already received treatment for that. That actually is an exclusion criteria right now, active substance abuse and untreated PTSD, where we want to also look at expanding that to those populations going forward to get more participants. But currently they want them already treated for PTSD before they come into the CBTI course.
And my other question is, because it is a self-sign-up, is there any concern about not having enough participants?
There is. Like I said, choose about 6 to 8 per session. Sometimes Greg's told me he's got 3 or 4. But there's not been one time, I don't think, that where they didn't do sessions. Even one small group. Yes?
Yeah, what are your thoughts about patients having polysomnography done? So is that going to be an exclusion criteria if they're on some type of either CPAP or BiPAP? Because, certainly that's going to affect their sleep efficiency.
Right. The studies that we looked at do have some data included in that, and that is not exclusion criteria for us.
Well, Bret, I really think this is very exciting, and I had occasion in the past to
actually wanted to find a volunteer job where I could actually do it. But one of the questions I have for you, could you address the measurement of sleep efficiency and reliability and validity?
So sleep efficiency is the number they're using at the Oakland Behavioral Health Clinic. Again, it's a standard number that they calculate out, taking self-reported total sleep time and self-reported time in bed. So it's quite subjective, but we do have them keep a sleep diary, so it's about as accurate as the individual reports are. So that's our basic validity. There is a construct of sleep efficiency scores I found in some other studies that I'm looking at doing calculations on the data they have to get us something a little more solid. This is another reason I want to add the ISI, which is subjective as well, but then I can compare sleep efficiency versus any changes in their insomnia severity index scores to see if they correlate. And if they do, that may increase my validity. They match up.
About the sleep efficiency, there is an app on the phone where you can actually put under your pillow, and when you go to sleep, you press it, when you wake up, you press it, and it will actually show how well you slept that night.
Yes, and there's a lot of wonderful things that are available, and I had this discussion with Bret. There is actually a CBTI coach. It's a free download. It was an app created by the VA. The validity was verified by VA practitioners. You can just Google a study on it, and it'll pop up. Unfortunately, due to the veteran population, they don't want them to exclude anybody, so they're doing everything on paper at this time, because they don't want to have some people on an app, some people on paper. So right now, that's not part of it, because I would love to do that.
And I have two thoughts. One is the IRB issue seems to be a bit of a concern from what you said, and I would just offer that obviously I haven't read this whole thing, but this appears to be somebody who's sitting on IRB and has actually gotten an IRB through the National Institutes of Health, a very low-risk study. So I think reaching out to the contact that Pamela gave you, perhaps at the VA and or some of us, I think we can help you with that, because I think we would want you to get IRB approval. So let's talk about that a little bit more. I think this is a very low-risk study to their participants, which is the main concern. Secondly, I have a question related to the pharmacology that's used by these patients and whether you're actually looking at that, tracking that, and will use that as a potential variable that gets considered, particularly related to SSRIs.
They are in my variable table, and that is actually the Veterans Affairs and the National Center for PTSD's primary suggestion is to use SSRIs and SNRIs first before any others, such as trazodone, risperidol, Remeron, and especially benzodiazepines, etc.
Because there is a pharmacogenomic component to those drugs, and so I could see many other studies after this study. So I commend you for what you're doing. Obviously, we have to remember that this is a start, but there are many other potential questions down the road, so great work here.
Thank you. Yeah, ideally we can come up with a non-pharmacological measure or an adjunct that will decrease the need for pharmacology.
Okay, last question, because we're got 2
This
seconds.
one's very short, not very scientific. I wondered if you've noticed all the commercials on TV for mattresses. And what they're always talking about is all these different things you can do in bed. You can work on your computer, you can read, you can watch TV, which is exactly what people should not do to improve their sleep. So I wondered if you've seen any of those.
Oh, absolutely, and that's why sleep hygiene is one of the tools to get on their intake, to get educated on that, and each week we ask them about the sleep hygiene tools that they're using. I wish I had used a lot more of those last night. I did stay up here, I didn't want to do the drive back from Monterey up here this morning, but yeah, I was thinking about this. So I do want to see all that. The quality, it was nice to understand what kind of mattress do you have? Do you have a mattress? Do you have, all those other details? Do you have a pillow? When did you replace your pillow? When did you last replace your mattress? Those would be all interesting things to see in here. But this time, I don't think we'll be able to collect that kind of data. I don't think it was collected before. Going forward, sure. I think it does matter if you have the quiet room and lighting. Like some studies will exclude night shift workers, or I was one, so I'm a vet. I would be excluded from the study because I work in the ICU at night.
And the bell rings.